Welcome, everybody, to Lipid Forum 2023. We're grateful that you chose to join us today. This program is a continuing education activity provided by Vindico Medical Education. We have an educational partner for the program, and we're grateful for the support of Purdue University College of Pharmacy for providing credits for our audience. The program is also supported by an educational grant from Novartis Pharmaceuticals. And I'm thrilled to introduce a wonderful faculty of people that not only do I have great respect for these folks, but I consider them friends, and they're all experts in the area of LP(a). We have Dr. Marlis Kaczynski, who is professor of the Department of Physiology and Pharmacology. She's a scientist at the Robarts Research Institute, Schulich School of Medicine and Dentistry at the University of Western Ontario in London, Ontario, Canada. We have Dr. Jessica Pena, Associate Professor of Clinical Medicine and Clinical Radiology at Weill Cornell Medical Center in New York. And Dr. Jamie Underberg, Clinical Assistant Professor of Medicine at NYU and director of the Lipid Clinic at Bellevue Hospital, and also past president of the National Lipid Association. I'm really thrilled to be able to present with this group of fine faculty today. Here's the agenda for this morning's program. We're going to start with a discussion of the pathophysiology of LP(a). Then we'll discuss the guidelines for screening and patient identification, appropriate measurement of LP(a), when, why, how, and in whom. So we're going to start with the discussion of pathophysiology of LP(a). This will be presented by Dr. Marlis Kaczynski. And Marlis, take it away.
Thank you so much. And so I want to just summarize the learning objectives, what I hope that you will be able to retain at the end of this presentation. So I hope that you'll be able to understand the following key points. The structure of lipoprotein A and ApoA, ApoA isoforms and the relationship to the determination of plasma LPA levels, and pathogenic mechanisms of LPA in atherogenesis. As well, we're also going to touch on the pathogenic mechanisms of LPA in thrombosis. So I like to start with this slide just to give you an idea of the global prevalence of elevated lipoprotein A. And as you can see here, there's approximately 20% of the global population that has elevated LPA. And if you look carefully, you can see that the percentage of individuals, so this is defined, by the way, as greater than 50 milligrams per deciliter, you can see it differs in terms of the percentage of individuals in that category in different countries. And the reason for that is differences in median LPA levels in different countries that relate to differences in ancestry groups. And I'll be touching on that again a bit later. So here is the structure of LPA. I like to start here because it's fundamental to understand this, to be able to follow some of the things that are coming later on in this session. So as you can see, LPA contains a low density or LDL-like portion, which you're familiar with. I'm sure it's got ApoB 100 associated, as you can see, with the lipid component of the particle. But what distinguishes LPA from LDL is the presence of this unique apolipoprotein called ApoA. And I've shown that schematically, and you can see it there. So what exactly is ApoA and why is it so important? So one thing to keep in mind that when ApoA was first characterized in terms of its sequence, and we understood a little bit more about what that apolipoprotein looked like, it was immediately evident that it was very similar to plasminogen. And that was very exciting for many people because here we had lipoprotein A, which was already known in elevated levels to be associated with risk for cardiovascular disease. But at the same time, Could there be a possibility based on this similarity with plasminogen, which is an important protein in the fibrinolytic pathway? Could there be a possibility to bring those two things together? Atherosclerosis and thrombosis sort of married in one risk factor. So it was very exciting. And that's why I'm showing you this. And then just a little bit more about these crazy structures. And you're probably looking at them going, what are they? They're called kringles in ApoA, and plasminogen has some as well, as you can see. But I just want to point out there's some very key, there's many, many kringles in ApoA and of different types. There's actually 10 different types, but we're just going to focus on the importance specifically of a couple of them that are important, again, for things that we'll be covering later. And one of them is what we call the kringle 4 type 2, and you can see it on the diagram on the right as well. That particular kringle is the basis of isoform size heterogeneity of LPA. So what that means is that it's present in identically repeated copies in as few as 2 or 3 to more than 40. And again, that is the basis of isoform size heterogeneity of LPA. The other kringle that's of interest is kringle 4 type 9, and you can see, if you look again on the diagram to the right, that's where ApoA is linked to ApoB100 in the LPA particle. The asterisk kringle 4 type 10 with the red asterisk, is really important as well, because that is where oxidized phospholipid is added to ApoA. And it's the oxidized phospholipid on ApoA that comprises probably the majority of the oxidized phospholipid that's carried by LPA in the circulation. And just for a little fun here, if you're wondering why these things are called kringles, the structure of these kringles resembles apparently a Danish pastry called a kringle, and that's where kringles got their name. So there's the pastry. There's the schematic of the kringle. I guess you can see it, but anyway, I thought you might find that kind of interesting and maybe make you able to remember kringles. So just compared to other lipoproteins, again, based on size and density, generally what we find and what others have found as well is that maybe with the exception of very, very large isoform sizes, generally we would find LPA in the density range of LDL, sort of at kind of at the bottom end of that range, as shown here, just to give you some perspective relative to other lipoprotein classes. So what's really important in this field is to understand how LPA levels are determined in the plasma, because they vary, as you probably know, tremendously, over 1,000-fold in the population, from less than 1, so essentially pretty much almost undetectable, to over 100 milligrams per deciliter. And in terms of expressing that in nanomole per liter, which is another unit of measurement for LPA that you will see from time to time, that corresponds to less than 1 to over 250 nanomole per liter. So tremendous range in levels. The second thing that's really important is to recognize that LPA levels are primarily genetically determined. In fact, LPA is the single most prevalent inherited risk factor for cardiovascular disease. LPA levels are highly heritable, and they have a codominant inheritance pattern, which means that, an individual's LPA levels reflect the LPA levels of each of the parents. So that's how an individual's levels are determined, and that's why we call it codominant. And it's also important to recognize that up to 90% of the observed variability in LPA levels in the population, and again, it's over 1,000-fold, but a lot of that variability arises from the LPA gene itself. And what's important here to recognize is that the extent to which that variability arises from the gene varies by ancestry group. And that's become more and more well known in the last decade or so. So the bulk of this arises from the inverse correlation between ApoA isoform size and LPA levels. So that's where the bulk of the variability occurs. So in other words, what we're saying here is that smaller isoforms tend to be associated with higher LPA levels than larger isoform sizes, which are associated with relatively low levels. Now, the contribution that makes to levels, in other words, the contribution that isoform size makes, ranges tremendously, though, between 30 to 60%. And again, that is dependent on the ancestry group. So that's important to realize. And again, we're just starting to get a really good handle on sort of LPA in different ancestry groups. So LPA levels are determined largely by production. So in other words, the steps that go into producing LPA, which is made and assembled in hepatocytes, rather than removal of the particle from circulation. And so that forms a good rationale for the design of LPA lowering therapies. And again, important to realize, of course, and a challenge for clinicians, LPA levels are comparatively resistant to conventional methods for LDL lowering. So there's little evidence, in fact, for a role for non-genetic factors in lowering LPA, including lifestyle changes. And statins generally are not too effective for LPA lowering and may, in fact, slightly increase it, but I don't really think that that is a statistically significant increase based on recent findings. And you'll hear more about that, of course, later in the session. So I'm just showing you this just to drive home the point that LPA gene variants that affect LPA levels, this gene is laden with genetic variants. And you can see the whole gene is kind of shown schematically here. And all these little things that you don't have to worry about are identifying various genetic variants. So there's many variants in LPA, which is interesting. But the important thing to remember, and I want you to remember from this, is that numerous variants throughout the gene that impact levels, yes, they're there, but the prevalence and extent to which these various, polymorphisms affect levels does again depend on ancestry groups. So that's a very important thing, again, to remember. So let's just talk a little bit more about the distribution of LPA levels. So again, that varies by ancestry. And I'm just showing you a figure that came from the, was recently reproduced in the European Heart Journal. But it's interesting because it shows here white individuals and Black individuals on the left, and you can see the graph corresponding to each in terms of levels. And what you can see is that in white individuals, and if you look carefully, and I kind of have to lift my glasses here to see this myself, the 50th percentile in white individuals corresponds to 19 nanomoles per liter. Now, if you look in Black individuals, you can see that it's a much more normal distribution. And in Black individuals, the 50th percentile corresponds to 75 nanomoles per liter. So again, LPA distribution in different ethnic groups is variable. So, and again, I just had a moment because it's probably too early for me yet in the morning here to think properly. But this is the UK Biobank data. If you want to look at this reference, you can find it within the European Heart Journal statement. But the important thing on the right panels to recognize is that the association of LPA with risk, first of all, it's a continuous risk between the association between LPA levels and risk is continuous, but it looks like that the magnitude of risk for a given LPA level is comparable between ancestries. So in other words, what we're saying is 50 mg per deciliter in a Black population confers the same level of risk as 50 mg per deciliter in a Caucasian population. And again, we don't have a lot of data on other ancestry groups. I'm always hesitant to make overgeneralizations, but this is the data for these two groups. So what's the evidence base for LPA and ASCVD? So I'm just showing you here, this is data from a 26-year-old male, elevated LPA, normal LDL-C, no other risk factors, and an acute extensive myocardial infarction. This individual suffered owing to plaque rupture of the left main trunk. And this individual had extensive atherosclerosis throughout the arterial tree. So that really supports the idea that LPA can be an independent risk factor for CHD and stroke, as was published in 2009 by a large meta-analysis. There's also evidence that it's causally associated with myocardial infarction using a Mendelian randomization approach, also published in 2009. And there were also 2 variants of LPA associated with cardiovascular disease. GWAS identified, in fact, in this study that LPA was the strongest locus associated with cardiovascular disease, and the 2 variants together increased risk almost 2-fold individually, and then together almost 4-fold. So these papers, 2009 was a great year to study LPA. If you were in the LPA field at that time, it was really exciting because this is really pivotal to sort of things that have come after, nailing down the independent nature of the risk, the causality, with respect to LPA being a causal risk factor for cardiovascular disease. So this was really important. So how does LPA cause ASCVD? So I'm just showing you a picture. This is a really old slide that I stained myself. It was from a 63-year-old male. We got this upon autopsy. It's a coronary artery cross-section immunostain for ApoA, which is in brown. So what you can see is extensive deposition. And early on, we recognized, like way back in the early 90s, that LPA can accumulate in atherosclerotic lesions to an extent that is directly proportional to its plasma concentrations. And within this milieu, LPA is selectively retained owing to the ability of ApoA to interact both with cells within the vessel wall, as well as extracellular matrix components in the vessel wall, like collagen and fibrin and elastin and so forth. So the biological actions of LPA, and I don't want you to try to look at all of the fine print here, but essentially there are pro-atherosclerotic effects and there are pro-calcific effects. We'll start with those 2 first. So for the pro-atherosclerotic effects, the majority of the data have come from looking at the effects of LPA on smooth muscle cells, endothelial cells, monocytes, and macrophages. So vessel wall components and components of arteries. And then the procalcific effects are interesting in that they affect both atherosclerotic processes as well as calcific aortic valve disease, which is a relatively recent sort of sequela to elevated LPA. LPA in elevated concentrations is a very strong risk factor for CAVD. So again, together, all the things that we found about the pro-atherosclerotic, the effects on the cells of the vessel, and the procalcific effects, again, both in the context of CAVD as well as in atherosclerosis, those can be tied together because they're all pro-inflammatory effects, which really started to make us think, okay, LPA is really, the way it works is probably by being highly pro-inflammatory compared to LDL alone. And also I want to touch on the prothrombotic effects today. And again, we've got lots of data that's been generated, a lot of it from our group, largely using in vitro systems. But just to remind you, I've shown here a ruptured plaque with a big thrombus in the middle of it to basically, sort of provide, a way of thinking about this, that LPA contribution, to a vulnerable plaque phenotype would then encourage, potentially plaque rupture and thrombosis. So oxidized phospholipids, and I showed this way in the beginning, are associated directly with ApoA. There's some also on the lipid part of the LPA particle, but the majority is covalently associated with ApoA itself. And there's lots of data starting in 2005 suggesting that the atherogenicity associated with LPA may be at least mediated in part by the action of these pro-inflammatory oxidized phospholipids. So in plasma, it was subsequently shown in 2008 that oxidized phospholipid preferentially associates with LPA. Okay, so any oxidized phospholipid on LDL, a lot of it will transfer over quickly to LPA in the circulation. And again, we talked about the fact that the oxidized phospholipid can attach directly to the Kringle 4, one of those Kringle domains in ApoA. And subsequently, there's just been a whole plethora of studies looking at what is this oxidized phospholipid on ApoA specifically doing. And here I've listed a whole bunch of different effects in a variety of different cells, including apoptotic effects in macrophages, increased IL-8 expression, arterial wall inflammation in response to exposure to this oxidized phospholipid, and the list goes on. So we have now, this is quite exciting, it's new, but it's quite exciting. We have now an LPA transgenic mouse, and we created that by, it's a double transgenic animal, so it's got the human ApoA gene, which unfortunately is called LPA, but that is the ApoA gene name. And we've got also in this double transgenic human ApoB. So I just want to point out a couple of things here, not to go into too much detail on this. Safe to say that in pretty much every parameter that we've looked at, plaque area, necrotic core area, calcification, and oxidized phospholipid staining, and you can sort of match those up to the panels on the right. But in all cases, compared to the ApoB mice alone, the LPA mice have increases in all of these things: plaque area, necrotic core, and calcification, which is really interesting, as well as oxidized phospholipid. There's a lot of oxidized phospholipid in the lesions from these mice, samples of which are shown on the right. So I'm not going to spend much time on this, just to say that how does this work? So what exactly is going on with this oxidized phospholipid? How does it have these effects? And pretty much in every vascular and inflammatory cell type that others and our group as well have looked at, basically it looks like it's signaling. So the oxidized phospholipid can trigger signaling pathways in all the different cell types I've shown here, whether it's valve interstitial cells, endothelial cells, smooth muscle cells, etc. And so within those cell types, it can have then unique pathogenic effects depending on the cell type. So this is kind of how we think that the oxidized phospholipid is working. So what about thrombosis? Everybody wants to know about LPA and risk for thrombosis. So again, on this slide, I've just summarized, and I'm not going to read it all, but there's been conflicting data, both for a role for LPA in venous thrombosis, against that, based on and really driven by large Mendelian randomization studies. Arterial thrombosis is harder to study, but again, you can see here there's conflicting data that are basically have been published over the years. And again, I have highlighted in orange the data that support roles for arterial thrombosis. I think venous thrombosis, pretty much people would generally agree that there's really not much there, but it really does seem like studies that have looked at the arterial thrombosis have seen relationships. So we have tried to do this to look at the effect of LPA, say, on fibrinolysis. And we've done this by looking at patients who received the antisense oligonucleotide that had dramatic levels, LPA level decreases, and no significant effects, as you can see on the bottom panel, in clot lysis time or clotting time. So this is looking at fibrinolysis. However, that is in a plasma clots formed in plasma under static conditions. And now we see that if we take whole blood clots, like in other words, formed with whole blood, and put them in flow and look at the question about fibrinolysis, we can see that LPA, as you can see on the left panel, has a relatively modest but significant effect on fibrinolysis, so a bit of an antifibrinolytic effect, and ApoA has a tremendous effect, but we don't see a lot of free ApoA, so that's not so exciting. So again, the question, does LPA promote thrombosis? So it could, as I've shown here, either inhibit plasminogen activation, or it can also, promote the formation of a clot by inhibiting tissue factor, plasminogen inhibitor, increasing platelet aggregation, or as I mentioned before, promoting a vulnerable plaque phenotype. What we've done is we've taken our transgenic mouse model and we have looked to see, using intravital microscopy and laser-induced injury to the vessels, which creates a thrombus, what we have seen, and the data are shown graphically on the left, is that there is an increase in clots in the LPA mice, so in the double transgenic mice. There's an increase in platelet volume, as well as an increase, as shown on the bottom panel, in fibrin volume. So, and again, ages ago, we showed in vitro that both LPA and ApoA could enhance platelet responses to a thrombin receptor peptide. So in summary then, I'm hoping that now by the end of this presentation, you will understand the following key points. You should have some familiarity with the structure of LPA and ApoA, specifically how they define the unique metabolic and pathogenic properties of this lipoprotein. ApoA isoforms, you should know what that means, different ApoA isoforms, and how they're related to plasma LPA levels. And recognizing that isoform size is a major driver, but there is this complex interaction with ancestry that we have to keep in mind. I've shown you and talked a bit about the pathogenic mechanisms of LPA and atherogenesis, and again, probably, likely, largely related to the oxidized phospholipid effects on vascular and inflammatory cells. And I also showed you a bit of data on LPA in thrombosis. So again, we're thinking now probably largely an effect on platelets. And again, the effect of LPA on fibrinolysis, as you remember, appeared to be less important. And I thank you very much for your time.
So our next speaker is going to be Dr. Jessica Pena, who's going to talk about LPA guideline screening and patient identification. Dr. Pena.
Thank you, Dr. Brown. Who should be screened and how we should do that. So I'll focus more on current society recommendations, and we'll also hear more from Dr. Underberg about how that should be done. So one approach to screening would be to screen all individuals, and many of you may have already developed views on this after already hearing about the risks associated with LP(a). And another would be focus screening based on individuals' risk factors or personal history. And it's also important to note that these are not mutually exclusive approaches. So I think the importance of LP(a) is really underscored by the number of societies and guidelines that have released statements about it. So we have the National Lipid Association 2019, the American College of Cardiology, American Heart Association, including it in their cholesterol guidelines in 2018, the Endocrine Society, Heart UK Consensus Statement, the Canadian Guidelines on Dyslipidemia, and then European Atherosclerosis Statement. So many different recommendations and guidelines. And you can see that there are many common features, and this makes sense from what we've heard. So family history of premature ASCVD, a family history of elevated LP(a), a personal history of ASCVD events, or those who have recurrent events, calcific aortic stenosis, we've heard already, and then as well as borderline risk of ASCVD. So this idea that you can use it to personalize risk assessment or as part of global risk assessment. As well as familial hypercholesterolemia. We know that those who have both familial hypercholesterolemia and elevated LP(a) are at greater risk than those who don't have either of those conditions. And then individuals with recurrent events or less than expected lowering on a statin. And I think this is an important point to note. Remember that the measurement of LDL includes the contribution of LP(a), and so individuals who do not have the expected, robust lowering that you would expect on a statin, that's a clue to think about elevated LP(a). And then this idea that we keep coming back to is once in adults as part of initial lipid screening. And so you'll see some similarities, I think, in some of these in the society guidelines, as well as some differences. Looks like the more recent guidelines or these statements have gravitated towards more universal screening. Many focus on individuals with high risk based on personal history, family history, aortic stenosis, familial hypercholesterolemia, this idea that you'd use it to personalize risk assessment. And then you'll see that the risk thresholds, the clinical risk thresholds that are advocated for use in practice are quite similar. So 50 milligrams per deciliter or 100 to 125, depending on the statement. And you've seen this infographic. I chose to highlight it again because I think it's a nice one to use in educational materials. And this was published by the National Lipid Association in their scientific statement with these primary prevention and secondary prevention guidance for who to screen. An important question came up earlier about who should be screening for LP(a). I think everyone, this is not just in the purview of cardiologists, certainly primary care doctors. I had a patient recently tell me that her gynecologist suggested she have it checked. So I think we absolutely all need to be a part of screening. We heard a little bit about the studies supporting the elevated risk associated with LP(a) from Dr. Kaczynski, as well as Dr. Brown. And I'll come back to this important study, which is a Mendelian randomization study in 2009 from Kamstrup and colleagues, using individuals in 3 Danish cohorts, showing that the risk of associated with elevated LP(a) of myocardial infarction increased such that those who were in the more than 95th percentile had a risk that was more than 2 times those in the lowest percentile. And this persisted when adjusted for Kringle-4 for clinical variables and Kringle-4 repeats. And another point that I'll reiterate is this idea that the risk of ASCVD is directly related to the level of LP(a). And a question that people have had is whether that risk was really just isolated to those with very high levels, and what the shape of the relationship was. And that was addressed in this large study from the UK Biobank, including over 400,000 individuals, which you've seen already referenced several times today, followed individuals for 11 years. And you can see that the shape of this relationship is linear. It's a linear relationship between LP(a) and incident ASCVD with individuals who have low levels. You see here having an incidence of 4 per 1,000 person years, and those highest levels here closer to 7. This, of course, we use in practice often use thresholds, but wanted to really emphasize this point that the risk is linear. If you look at individuals who have the highest levels, so using a cut point here in that same UK Biobank study of 150 nanomoles per liter, roughly 70 milligrams per deciliter, and individuals who did not have ASCVD at baseline, which I saw some questions also in the chat about, you can see that that represented about 12% of the population, and that those individuals had a hazard ratio of 1.5 for ASCVD, so this is really primary prevention, and that those who had ASCVD at baseline, they represented more, 20% of the population, but their hazard was actually lower. Hazard ratio was closer to 1.1. And what about aortic calcification? Are the thresholds similar? On the left, you'll see this is a study using population data from the Rotterdam cohort, and then they also added in individuals, younger individuals who had a family history of events who were being seen in a clinic. And the levels of LP(a) that were greater than the 80th percentile, or 50 milligrams per deciliter, were associated with aortic calcification. And the prevalence of that was nearly 16% among middle-aged adults. Similarly, in a Mendelian randomization study, the EPIC Norfolk UK study, this threshold, more than 50 milligrams per deciliter, was associated with double the risk of aortic stenosis, and this persisted after adjustment for risk factors, and the same was true in this Rotterdam and Amsterdam cohort study. We have heard from Dr. Brown also about the data regarding increased risk of progression. And so while the guidelines are consistent, you'll see many different values in guidelines and papers. And so some of this is due to differences in measurement techniques. So we talked about the difference between nanomoles per liter versus milligrams per deciliter, which I know Dr. Underbrook will discuss some more, as well as heterogeneity among studies, some studies using absolute thresholds versus population medians or percentiles, and then of course the variation by ancestry. And again, to underscore the point that Dr. Koczynski already made, while the median levels in different populations, this is the same data from the UK Biobank study. So while these median levels are different, you'll see here white, South Asian, and Black individuals. Black individuals had levels that were about 4 times those of white individuals, that the magnitude of risk is similar across groups. And this was using self-identified race ethnicity. So you can see here no heterogeneity. And they looked at risk per 50 nanomole per liter increase in LP(a), as well as these thresholds, a threshold of 150 nanomoles per liter, and then also using a race-specific percentile. So this magnitude of risk similar across the race and ethnic groups. So in addition to the data that we've reviewed already about population screening, I think it's also important to think about other population approaches such as cascade screening. These are data from individuals presenting with dyslipidemia to a lipid clinic who underwent cascade screening for LP(a), and they were included if they had an LP(a) greater than 100 milligrams per deciliter. And you can see here that for those individuals, the yield for finding family members, affected family members with an elevated LP(a) is defined by more than 50 or 100 milligrams per deciliter was high. So one new case for every nearly two relatives tested, and one new case for every 3 relatives tested for 100 using a threshold of 100 milligrams per deciliter. This has also been shown in individuals with familial hypercholesterolemia. So as you know, familial hypercholesterolemia, cascade screening is advocated for detecting affected family members. And so this study of individuals in the Western Australia cascade testing program using opportunistic testing for LP(a), where individuals, family members were screened for familial hypercholesterolemia and LP(a), using 62 probands and 162 relatives. You can see that There's one case, similar numbers, one case detected for every 1.5 relatives tested for familial hypercholesterolemia. And then elevated LP(a), one case detected for every 2 relatives tested, and then one case detected for every 3 relatives for those with FH and LP(a). We've seen a similar approach. These are data from the SafeHeart study, which is a prospective cohort in Spain with 775 probands and nearly 3,000 relatives screened, and using a systematic approach. And you can see here very similar data where systematic screening was resulted in detection of 1 in 2 individuals, 1 in 2.4 individuals with elevated LP(a), and 1 in 3 who had elevated LP(a) plus familial hypercholesterolemia. So something to think about as we think about how to screen populations, perhaps incorporating LP(a) into existing cascade screening programs for FH. So I'll stop there and hand it over to Dr. Underberg.
This is a talk entitled The Measurement of Lipoprotein A, When, Why, How, and Who. But I would subtitle this Stuff I Think About, because that's really what I've tried to do here, is put together a lot of different concepts that impact those of us who do clinical care in the setting of either cardiology, internal medicine, preventive cardiovascular medicine, lipidology, which is what I do, and how we think about some of the great data that's been presented by my colleagues already today. So some of this might seem duplicative, but trying to present it from a different perspective. And I thought I'd just start out with a case, because that's how I was always trained with presentations, to start a case. So here's a 29-year-old female with a known history of high cholesterol for 10 years, diagnosed at age 19 during routine screening in college. A strong family history of premature ASCVD. Her mother and maternal grandmother, both with MIs in their late 50s, and an older sister with a stroke during pregnancy at age 23. She had an LPA measured at age 27 and told it was elevated at 50 milligrams per deciliter. Recent repeat testing was done as part of an executive health exam and again shown to be elevated, but now measured at 118 nanomoles per liter. So she comes in concerned about the apparent worsening of her LPL, about A elevation, and what this means for her now in the future. And obviously, the increase is due to the fact that the metrics have changed and she's being evaluated based on nanomoles per liter versus milligrams per deciliter. Often 30 is listed as the cutoff for normal in laboratories that do milligrams per deciliter. We often think of 50 as the cutoff for risk. 75 is often listed as normal for nanomoles per liter, but often risk takes off somewhere around 100 to 125, depending on the guidance you're looking at. But again, you show the fascinating data that was shown earlier by Dr. Pena, looking at the linear relationship of LPA to risk. And so this concept of the cut points or cutoffs or thresholds, I really think needs to be thought about within this concept of linear relationship. I don't think this is a binary report, high or not high, and I really think we have to start moving away from that. And again, that's just one of the things I think about. So just a bit of an outline. Why is LPA measurement important? Challenges with regards to measurement, and I have my own take on this. Approaches to measuring it and how to avoid under or overestimation of LPA. And again, LPA is an issue worldwide. And if we think about the percent of the population that has an LPA greater than 50 milligrams per deciliter, 20% of the world population is thought of in this group. You can see that this is an issue worldwide, globally. And so certainly something we need to all be addressing. And you've seen this diagram before, but again, that 20% in red is the group that we often think about at being at increased risk and need for consideration. And again, the linear relationship, I think in my mind, changes how we think about this in patients with elevations. And so I think it's important to realize that lipoprotein A concentrations predict incident ASCVD amongst adults within primary and secondary prevention context. And this risk is a linear gradient. Concentrations are variable across racial subgroups, but the associated risk is similar. And you saw some of the data that Dr. Pena presented around the variations in how we think about levels, but the consistency in risk across these racial and ethnic subgroups. This is a series of 2 slides from a friend and colleague of all of ours, Dr. Tom Dayspring, and you can recognize his graphics from a mile away. But I just want to again remind everyone of what LPA is. It's LDL with ApoA bound by that disulfide bond to the Kringle subunits. And so when we think about LPA, we're thinking about an ApoB containing atherogenic lipoprotein particle, along with all of the other atherogenic lipoprotein particles, VLDLs, IDLs, LDLs, and chylomicrons potentially. I think what's key to understand when thinking about what LPA really measures is that LPA is measuring the cholesterol in the LDL ApoA containing atherogenic particle pool, so to speak. And so again, thinking about what represents ApoB, ApoB is all of the LDL containing particles and the LPA containing particles. But the LDL, the cholesterol contained therein, can also be broken up the same way, meaning this quote, real LDL cholesterol is the cholesterol contained in the ApoB LDL particles that do not have ApoA attached to them. And the LPA cholesterol is the cholesterol in the LPA LDL cholesterol, so to speak. And all of that makes up total LDL. Well, why is this important? It's important because, again, if your LPA is significantly elevated, that means a significant amount of the LDL is actually LPA. And as LDL goes up, if LPA is higher, a greater amount of LDL is actually lipoprotein A. And so this is, I think, an important way to think about how we investigate patients who have elevated LPA. So why would a clinician measure lipoprotein A? Well, a couple of bullet points here that I think are key and important. Elevated LPA is a common independent ASCVD risk factor that's not measured, unfortunately, in the majority of patients who are affected by it. So the more we talk about it, the more we think about it, the more I think people will have this checked. People often will say to me, I don't understand why one would measure this because there's nothing you can do about it. And I can't think of anything more wrong. In my mind, if you said that, then you would also probably say, why should we talk to someone about their family history, right? Because you can't do anything about their family history, but it certainly changes the context by which you view everything else about their medical care. Second, the only currently available method to know if someone has elevated LPA is to measure LPA with a simple blood test that's relatively inexpensive. We've heard in the Q&A that it's covered. As long as you use the appropriate diagnosis codes, E78.41 here in the US, it's going to be covered. Awareness of the presence of elevated LPA is important because high LPA increases ASCVD risk and could inform clinical decision-making regarding overall risk management, right? Not just regarding lipids, but regarding high blood pressure, weight management, diet, lifestyle, exercise, counseling about other risk factors for cardiovascular disease. And then you heard some great data already about the role of cascade screening. Once you find LPA in one individual, it's important to go back and speak to the index patient about screening all first-degree family members. Again, here in the US, we have to rely on individuals to speak with their family members about it. But I have to tell you, once this is identified, if you actually spend 5 minutes talking to someone about the importance of screening their family members, it often gets done. It's one of those things that gets communicated when people find out about it. So how should one measure LPA? With an isoform insensitive assay. an assay that is traceable to the internationally accepted calibrator, which is the World Health Organization, and an assay that's reported in nanomoles per liter. Now, you've seen a lot of clinical trials up until now, and the metric that has been used has been milligrams per deciliter. And this is an issue because much of the data is in milligrams per deciliter, but we now have organizations and recommendations suggesting that it should be reported in nanomoles per liter. And as part of those recommendations, experts around the world have also made recommendations that clinical studies should also be done going forward in nanomoles per liter. If measurements are not uniformly calibrated, one cannot compare measurements generated by different assays. So this is information from the National Lipid Association guidance on laboratory measurement of lipoprotein A. And we have class of strength recommendations here. For the measurement of lipoprotein A, it's recommended, again, that assay that is calibrated, as I mentioned, is a recommended guidance. And when using values for clinical risk assessment, it is not recommended that one use conversion factors to try and convert LPA values from milligrams to deciliter to nanomoles per liter. I see people often trying to do that, multiply by certain kinds of equations. It is not recommended that you do that. And when LPA values are used for risk assessment, this recommendation was in Caucasian patients, reasonable to use measured values of 50 milligrams per deciliter or 100 nanomoles per liter, suggesting increased risk. But we've seen interesting, more recent data around the linear relationship there. So I do think that going forward, we may want to think more broadly about this. Lipoprotein A testing in clinical practice. I think, in my mind, the question is really who not to measure lipoprotein A in rather than who should I be measuring lipoprotein A in. But if one were looking for groups of patients to make sure you did not forget to measure lipoprotein A, I would say individuals with a family history of first-degree relatives with premature ASCVD is certainly one. Individuals with premature ASCVD, particularly those in the absence of traditional risk factors, individuals with primary severe hypercholesterolemia such as FH, and individuals at very high ASCVD risk to better define potential additional therapeutics, such as maybe PCSK9 inhibitor therapy, LDL apheresis, or maybe putting people in clinical trials for newer therapeutics with regards to LPA measuring. I think when it comes to other roles for lipoprotein A measurement, patients who are in the borderline risk categories, the 2018 guidelines specifically list lipoprotein A as one of the additional risk modifying tools that we can use to further personalize risk for individuals. And so in patients who fall into borderline risk categories, I think measuring lipoprotein A might be useful. Now, the National Lipid Association also makes some interesting treatment recommendations on things that it may be not recommended to do. And I think it's just important to be aware of this as what we recommend patients do or providers do. And so one which we've heard a little bit about already is niacin, which lowers lipoprotein A, is not recommended to reduce ASCVD risk. And finally, the other that often gets asked is hormone replacement therapy. And so right now, the National Lipid Association is not recommending the use of this in patients with elevated lipoprotein A as a way of lowering lipoprotein A. And so in this NLA statement, which I think is still worth highlighting, in statin-treated patients, it's important to know that a high LPA is still an independent risk factor for ASCVD. And in patients who fall into intermediate risk calculated pools, it's also important to think about this as a risk-enhancing factor, as identified in the guidelines. The presence of an elevated lipoprotein A in patients with ASCVD and baseline LDL cholesterol levels greater than or equal to 70 milligrams per deciliter can be used as an additional factor to determine whether or not we should be more aggressive about LDL lowering. And finally, I already mentioned the niacin and hormone replacement. But we do have even more recent guidance, and this is from the EAS statement. And again, you heard a really nice overview of all these guidelines from Dr. Pena. I just want to highlight what I thought were some really key components of that EAS statement with regard to the context of my talk, which is that one, very low LPA may actually associate with increased risk of type 2 diabetes. And this is certainly just something to be aware of. It's just a clinical pearl, but again, if you find someone in that category, it's worth at least making sure you've gone back and evaluated their glycemic status. Probably not a risk factor for venous thrombosis. And again, you heard some really elegant data from Dr. Kaczynski about this. I do think it's something to be aware of. I do think thromboembolic disease is not the same as venous thrombosis, and it's important to differentiate those two terms. Some people use them interchangeably, and it's important to realize this. The risk factor for aortic stenosis, I think, is really key and important. And one of the things I just want to throw out here as a clinical pearl is that many of us see patients who have been previously diagnosed as having bicuspid aortic valve. And they're often getting followed with their yearly echocardiograms. They're being seen by a cardiologist. Patients with bicuspid aortic valve disease who have elevated lipoprotein A can progress at a rapid rate. And if you have a patient with bicuspid aortic valve disease, I do think it's important to know their lipoprotein A status and consider perhaps monitoring them on a more frequent basis. The EAS statement also, I thought, was very powerful in their recommendation that LPA should be measured at least once in adults. And I think we're moving in this direction, whereas in the National Lipid Association recommendations, they were listed just for specific risk groups. Interpretation of LPA should be in the context of global ASCVD risk, intensifying risk factor management, and again, looking at the potential for enrolling patients in LPA lowering trials. I do want to speak a little bit now about familial hypercholesterolemia, which is a space that I spend most of my day in. And so again, stuff I think about, this is something I think about. And when it comes to lipoprotein A levels in FH, it's important to remember this is a very important risk modifying tool. And this is just some data also from SafeHeart. This is a Spanish registry of patients with familial hypercholesterolemia, reminding us that if we look at patients' LPA levels and compare non-FH to FH patients, in patients with higher LPA, you see this dramatic takeoff in risk the higher the LPA levels are. It also allows us to risk stratify FH. If we look at men and women with high and low LPA levels, you see that having higher LPA levels versus lower LPA further risk stratifies both men and women with familial hypercholesterolemia. But we can also use it as a way of thinking about global burden of LDL cholesterol over the course of a lifetime. And again, for those of us that think about lipids all the time, we tend to think not just about the level, but for how long have you been exposed to that potential risk factor, very much the way we think about pack years in cigarette smoking. We now think about cholesterol years. And if you look at the timeline of LDL and the percent of patients with ASCVD, and you break it down into those with lower and higher lipoprotein A levels, and the cut point here was 50 milligrams per deciliter, you can see that having a higher LPA level gets you to a greater risk of ASCVD at an earlier time point. And this is seems to be greater in patients who are older. And that makes complete sense because they have a higher burden of LDL exposure, greater risk associated with greater age, greater differential in that associated risk with high versus low lipoprotein A. But another way of thinking about this here is just looking at FH patients, and again, LPA levels being high or low, and having or not having FH. And you can see that the group that has the highest risk are the patients with FH and the patients with elevated lipoprotein A. Now, I would tell you that for a very long time, we've thought about FH and LPA as a dual kind of risk, and that I remember being taught early on that lipoprotein A is associated with familial hypercholesterolemia, and one should think about these two together. And when you have someone with elevated cholesterol in the setting of what you believe is inherited high cholesterol or familial hypercholesterolemia, immediately think about elevated lipoprotein A. But I'm going to show you that our thinking on that has changed somewhat. So here again is just some data looking at hazard ratios for myocardial infarction in patients with familial hypercholesterolemia or not. And so you can see here clinical FH, no, clinical FH, yes, and then elevated or not elevated lipoprotein A. And again, the group with the highest or greatest hazard ratio for myocardial infarction are those with FH and with elevated lipoprotein A. But I want to just go over this important concept of how we think about the way LDL impacts the way we view someone's lipid profile in the setting of an elevated lipoprotein A. And I thought this was a wonderful paper. I recommend everyone to read it. It was published in the Journal of the American Heart Association in 2020, and it gives this wonderful visual example of how to think about LDL and lipoprotein A. I listed this as a rigadoon. A rigadoon is a lively dance for two, and that's the way I think about this balance between LDL-C and LPA. And so you can see here on the left, this is a patient who has a normal LPA level and a total cholesterol of 150. And this total cholesterol of 150 will stay the same, but then we will slowly increase what the LPA level might be in this patient. And you can see with increasing levels of lipoprotein A, while the total LDL stays the same, right, 150 milligrams per deciliter, when you get to the highest level of lipoprotein A, you can see that the actual measured LDL gets down to less than 20 milligrams per deciliter. And so again, in patients with very high LPA levels, in the setting of total cholesterol, you have to remember that the amount of LDL gets lower and lower the higher the LPA does, even though the total cholesterol might potentially stay the same. So this gets back to this very important concept of the way we think about LPA and LDL, especially in patients with FH, and this concept of what we now call ascertainment, or what I call diagnosis bias, right? So that in someone who is seen with a very high LDL cholesterol, with a clinical diagnosis of familial hypercholesterolemia, there seems to be a greater association of elevated LPA. But it turns out that's only because many patients with a clinical diagnosis of familial hypercholesterolemia are actually misdiagnosed as having really elevated lipoprotein A, but the LPA has not been measured. And so that they may not have a monogenic cause of FH, but their elevated LDL is because of their elevated lipoprotein A. And so while I think it's important to measure LPA in anyone with FH, be careful and don't misdiagnose FH as elevated LPA, and make sure you go through the appropriate diagnostic algorithms for FH, or even consider genetic testing and also measure LPA, because you could be misdiagnosing one as the other. There are a variety of medications that may impact lipoprotein A. I've boxed out here PCSK9 inhibitors, which lower LPA anywhere between about 14 and 30%. Interestingly enough, statins, as we've alluded to in this talk so far, actually have been shown to raise LPA in many clinical trials. And I've actually had people call me and say, gee, my LPA went up when I was put on a statin. Should I be worried? And again, things that I think about. This is one of those things I think about. And we actually have some really nice data now that was published in the European Journal of Preventive Cardiology. Dr. Brown alluded to this earlier. It was a systematic review and meta-analysis of randomized trials with a statin and a placebo arm, looking at statin therapy and elevated LPA levels. None of the types of statins changed LPA significantly compared to placebo, as well as intensities of statin, right? So that if someone is on a statin and their LPA goes up, and they ask you the question, should I try a different statin or a different dose to impact my LPA level? The answer should be no. But the second, and I thought more important piece of data from this, was that statin therapy did not lead to clinically important differences in LPA compared to placebo in patients at risk for cardiovascular disease, the findings suggesting that in these patients, statin therapy will not change LPA-associated CVD risk. But what about how much do we need to lower LPA to make a difference, right? We've got clinical trials in development, and we've got some medications now, such as PCSK9 inhibitors, that lower LP(a). Well, if you go back and you look at the accrued data on LDL cholesterol, it seems that you need to lower LDL cholesterol somewhere about 30 or 40% to really move the bar with regards to risk reduction. And you can see here, that means going from the 90th to the 50th percentile, or for the 50th percentile, down to probably around the 20th percentile. Well, if we look at similar data regarding regarding lipoprotein A, and much of this is generated from fascinating genomic analyses, probably you need to lower LPA somewhere around 80%. And some people believe it's actually absolute changes in LPA, much like it is in LDL cholesterol, that move this bar. So I think that when we're looking at future drugs in development, it's robust changes in LDL cholesterol that I think really make a difference. And so when it comes to key take-home messages, LPA is an inherited trait transmitted independentally of cholesterol. It's associated with increased risk of ASCVD, calcific aortic stenosis, and I put thromboembolic events in a separate category because of some of the varying data in that space. Strong family history of premature ASCVD, stroke, premature calcific aortic stenosis obviously should all have their LPA measured, but perhaps all adults should have LPA measured once in their lifetime. But what about children? I think that's a whole nother area up for debate. LPA is a risk modifier in the primary prevention algorithm in the 2018 Multi-Society Cholesterol Guidelines. NLA consensus statement is well worth a read, as is the AHA recommendations that we've alluded to in this talk so far. Alan showed you some of the ways to think about risk in that group. And I think LPA should be measured in all patients with known or suspected familial hypercholesterolemia.
Today we're going to be speaking on current and emerging therapies to reduce LP(a). And we've got a tremendous faculty today, all wonderful people and definite experts in the area of LP(a). We have Dr. Patrick Moriarty and Dr. Jamie Underberg. Here's the agenda for today. We're going to have a discussion on current approaches to reduce LP(a), then emerging therapies for LPA reduction. So we're going to start with the first presentation, and I'm honored to introduce my friend and colleague and really a terrific expert in the area of LP(a), Pat Moriarty. Pat's a professor of medicine and clinical pharmacy and director of the Atherosclerosis and Lipid Apheresis Center at the University of Kansas, and also a past president of the International Society for Apheresis. Take it away, Pat.
Well, thank you, Alan, and good day to everyone there. I mean, LP(a) and present-day therapy, as Alan said. But before I do that, I'd like to bring up this article that was published in the European Heart Journal last fall by the European Society of Cardiology and also the European Atherosclerotic Society, and I was a co-author of this, recommending that everyone should be tested at least once in their lifetime, if not more, for LP(a) levels. This is a guideline in Europe. It's actually a guideline in Canada. We don't have it here yet, but it's only a matter of time before it arrives. So let's move on to what can affect plasma LP(a) levels in simple life. Things that it can increase is FH patients. Then notoriously can have LP(a), 40 to 50% of them can. Pregnancy, menopausal symptoms. But more importantly, I think you should know that chronic renal failure, nephrotic syndromes, are classically found to have high LP(a). The mechanism, we're not sure. We think it's the degradation of LP(a) is partially done in the kidney, so we think that could be the mechanism. And what can decrease LP(a), hypothyroidism, actually estrogen, that therefore women go into menopause and their estrogen levels go down, their LP(a) levels might go up small amount. Liver disease and other such diseases. Next slide here. So what can lower by lifestyle? Well, unfortunately, low fat, with low or high vegetable diet raises LPA levels. Not significantly, but has no significant effect on lowering them. And physical activity, unfortunately, has little effect on LPA levels. Both of these still are very effective in reducing cardiovascular disease and cardiovascular disease risk. What about aspirin? Well, aspirin has been shown in years to have a modest effect on lowering LPA and also lowering cardiovascular events. But as we know now in the field of primary prevention, it's been recommended by the guidelines not to necessarily use aspirin because of the complications associated with it, significantly bleeds. Well, in this recent study called ASPREE, which involved elderly patients over 60 years of age, and they broke down the groups from patients with normal LPAs or high LPAs or a genotype, and they found the patients over 60 who had high LPA had a significantly better reduction of MACE events if you treated with the MACE events are higher than the bleeding events associated with taking aspirin. So it's wise in patients over age 60 with high LPA and primary prevention to consider low-dose aspirin. What about therapies? Well, lipid apheresis, as you can see on top, I'll discuss that in detail much later. Nicotinic acid, which I'll go over also. The PCSK9 inhibitors, again, I'll touch that. Mifepristone is a drug that's off the market, unfortunately, but it had some effect. Lomidopide really has modest effect. And statins, unfortunately, can raise LPA, but I'll talk about that shortly. And azethamides, fibrates, and bile acid sequestrants really have little to no effect. So let's talk about niacin. Niacin does lower LPA levels. And early in my career, I was using it quite extensively in my LPA patients until data such as the AIM-HIGH, as you can see here, and other trials showed that even though niacin can lower LPA, its effect on clinical outcome is not of any significance. This is statins and placebo, statins and niacin, and you show with high LPA, there was no clinical benefit. This is event-free. So we're finding that it doesn't have any clinical benefit. And this could be because of the other effects that niacin might have in the sense of raising blood glucose levels or additionally raising uric acid levels, which have been shown in studies such as Colcott to be associated with cardiovascular disease risk. What about statins? Well, as I mentioned, statins can potentially raise LPA, but because they lower apoB-lipoproteins, LDL, it still can lower events. And here's an example from Paul Ricker's group, published in the New England Journal of Medicine many years ago, the Jupiter trial. These are high-risk primary prevention patients who were put on rosuvastatin 40 milligrams, followed for a period of 4 years, and show the reduction of LDL, as you can see, from 108 to 55, almost a 50% reduction, and a reduction of cardiovascular events by over 40%. Well, post-study, they did a retrospective analysis to say, well, let's see what happens to the patients who had high LPA in the study compared to the patients who had low LPA. What did they find? Well, they found that there was a reduction. The primary endpoint showed a reduction of the events, in the sense of reduction of events. In the primary endpoint plus mortality, there was also a reduction. But as you can see here, there was a significant benefit. So even though statins can raise LPA, by lowering the LDL, it will be another risk factor for cardiovascular disease. It might be attenuated, but they still receive benefits. So I never refuse offering statins to patients based on their LPA level. Let's go to the next slide. PCSK9 inhibitors. PCSK9 inhibitors, as you know, can lower LDL quite dramatically, but also has effect on LPA. And this is from the Fourier trial, which was using evinacumab. And you can see in the LPA low medium, which is only 15 milligrams per deciliter compared to the high medium, the number that you treat to reduce an event went from 105 down to 40. More than half benefited based on the LPA level. If you look at LPA of 120 nanomoles, which is 50 milligrams, which is considered high LPA, again, you saw a number that treatment from 71 down to 41. Significant change. The problem with the, well, not problem, but the difference with PCSK9 inhibitors and LPA, they're not consistent in lowering LPA. You can see here the quartiles of the LPA and the amount of LPA reduced. But when you look at the percentage reduction, when you get up to a high LPA, The reduction is only 16%, while in the second quartile, it's up to 40%. So when you have a low LP(a), you get a bigger bang for your buck with the PCSK9 inhibitor. And here's the Odyssey trial, Odyssey outcome, which had alirocumab. You could see the same outcome. In fact, in the patients with the quartiles of the third or fourth quartile of high LP(a), they're the ones who had the best reduction of MACE. Irrespective of LDL, the ones with the highest LP(a) had the best bang for their buck, even though it was adjusted. So, unfortunately, PCSK9 is not approved for treating LP(a) at this present time. Apheresis. Now, presently, the use of lipid apheresis are really major three groups. Primary prevention with LDLs over 300 on max pharmacotherapy, or secondary prevention with patients with LDLs greater over than 100 milligrams per deciliter on maximum pharmacotherapy. And the third group that was approved not too long ago by the FDA was patients with LDLs over 100 and an LP(a) over 60, which really doesn't make much difference from group B, but we'll talk about that later. So to go back on how this developed, this is the German Lipid Apheresis Registry, or GLAIR. It was launched in 2008. And during 2012-2020, 89 German apheresis centers collected retrospective and prospective observational data of over 2,000 patients undergoing regular lipoprotein apheresis. And the German approval for treating LP(a) includes an LPA level above 60 milligrams per deciliter, like we have in the United States. But the LDL baseline levels are not required, meaning you have a cardiovascular event history that's ongoing and your LPA is elevated, you are approved for apheresis. So, with that information, apheresis in Germany is 10 times more prevalent used than the United States, even though we're 6 times their size. And this is their outcome from the GLAIR data that was just published recently in the Therapeutic Apheresis Dialysis. You can see after 1 year of therapy of apheresis, the event rates, this is the event rate for the patients before starting apheresis. So the control group is their history before apheresis. And you can see reduction was 83%, and it persisted now out to 7 years. With that knowledge, I'm very familiar with the group at GLAIR, and I asked them if they could show me their data of LP(a) levels being treated with apheresis on patients with LDL levels above 100, 100 to 70, 70 to 50, and 50 and below. And I presented this data that they gave me at the American Society for Apheresis meeting in Philadelphia last May. And this is what we found. Patients' MACE rate on apheresis was dramatically reduced, as we showed earlier, but it was even more reduced when the LDL was less than 50 compared to 100. And when we looked at the safety aspect of it, the average AEs per patient was about the same, if not better, with low baseline LDLs, and the AEs per treatment were about exactly the same, showing that there is safety and efficacy in treating these patients. So let's go to our center in Kansas City. We actually have the largest apheresis center in North America, and of our groups, we presently treat 52 patients that have high LPA with or without high LDL. This is a paper we published 4 years ago looking at a small group of our LPA patients with LDLs less than 100 and LPAs of over 130, you can see 130 milligrams per deciliter. This is their event rate before starting apheresis. We looked at 12, 72 months or 6 years. They had 36 events, MI, CABG, stents, and stroke. And then we followed them for 48 months or 4 years and found that we only had 2 events, which resulted in 94% reduction, and those 2 events were just placements of stents. The age group was 11 to 66. So how does LPA apheresis work so well in these patients? By treatment, their LDL goes down dramatically, but it bounces back up after a week or 2, and there's an average reduction of chronic about 30%, but the dynamic results we get is quite interesting. So let me try and explain that. This is how apheresis is performed. We remove the blood through a plasma separator. The plasma, which has the ApoB, goes through this dextrin sulfate filter, which is a negative charge filter to capture the positive charge proteins, which include ApoB. And as you can see here, the LDL have ApoB, so they bind to these dextrin sulfate filters. HDL which is negative charge, is not supposed to be removed, but actually is. A significant amount is being removed in different devices, which made me years ago wonder what is the mechanism of action. Well, it's a little bit complex, and as you know now, we learned that HDL is not a consistent benefit for cardiovascular disease prevention. In recent studies, and this is published in JAMA Cardiology last year, showing that the shape of the benefit is a U-shaped curve, where low HDL and high HDL can increase risk of cardiovascular disease and death, both in men and women. And this gets complicated, I know, but let's start with apolipoprotein E. It contains 3 alleles, E2, 3, and 4, and 6 genotypes. And the pleiotropic effects of ApoE involves coagulation, oxidation, geocell, neural cell homeostasis, CNS physiology such as dementia, and inflammation. And ApoE4, which is ApoE4, isoforms can have elevated levels of small dense LDL, low HDL, and increased LPA. And as we can see, the ApoE4 has been shown, genotypes have been shown to be not only associated with dementia, but also with cardiovascular disease. And in patients with FH, their HDL levels are low. We don't really realize that, but FH patients have a high LDL, but they also have a low LPA, low HDL. And in this analysis here, looking at ApoE4 isoforms, they found that was the best reason or most consistent correlates, variance of determining why you had a low HDL was because of the ApoE4 bound to it. To make things even more complicated with HDL, we now will learn that there's something called HDL particle concentration, which you can measure through a nuclear magnetic resonance or NMR. It is a predictor of benefit of the HDL molecule. So the higher HDL particle number compared to the higher the LDL particle number, it's actually beneficial in reducing cardiovascular events, stroke, MI, or even when adjusted for HDL, it still shows clinical benefit. Most recently, it was found that a high HDL particle number with a ApoC3, apolipoprotein C3, which binds to HDL also, predicts reduction of progression of aortic valve calcification, which is found commonly in patients with high LPA. In apheresis, in our analysis and others, have shown that the reduction of ApoA1, ApoA2, which is commonly bound to HDL, is not significantly removed, and these are good apolipoproteins, proteins, where ApoB, ApoC2, C3, and ApoE is significantly reduced by lipoprotein apheresis. And we found in a paper of ours a few years ago, looking at ApoE4 and total HDL post-apheresis, the reduction of the ApoE4 was consistent with the total of HDL. So there was a significance that the ApoE4 was bound to the HDL. I know this is kind of confusing. Now, the effect of lipoprotein apheresis on HDL, this is another paper that we presented years ago at the AHA, and we showed that the particle number of the Japanese machine, which is the liposorber, increased HDL particle number by 28%. And the reduction of ApoA1 compared to HDL was much less. So again, removing an HDL that might be considered a dysfunctional HDL, because HDL is a very complex molecule. And more recently at the European Society of Cardiology, we looked at HDL proteomes, because there can be up to 100 different proteins bound to HDL. And we found the ones that are reduced by apheresis are all these negative proteins, such as serum amyloid A, ApoC3, ApoE, where these positive proteins and sensitive for functionality seem to be increased by apheresis. Let's move on to another aspect of apheresis. This is looking at inflammatory markers. And these are reduced acutely and chronically with apheresis. CRP is reduced by 65% acutely and chronically by 50%. Interleukin-6, major interleukin, and recently in the COVID pandemic, is reduced by about 35%. But not only plasma reduction, but in a study that was done by Eric Strozen's group in Amsterdam, looked, and it was published 10 years ago in JACC. They used measuring with the FDG PET scanning. They looked at the inflammation not only in the lumen, but also in the wall of the arteries. And they found that the inflammation was reduced significantly post-apheresis within the wall, which would come out to be something called plaque stabilization. Finally, rheology. This is another complex part that I hope I don't confuse you here. And rheology and viscosity is the science of blood flow in relation to pressure, flow volumes, and resistance in blood vessels. So viscosity is equal to resistance over 8 times the length divided by pi to the radius to the 4th power, or shear stress over shear rate. And if you have a vessel that's length does not change and its radius does not change, such as a capillary, then the viscosity of that fluid has to equal the resistance and vice versa. So the resistance to flow is based on the viscosity of that fluid. Why is that important? Well, blood, unlike plasma or water, is a so-called non-Newtonian fluid, meaning forces placed upon it, such as shear rate and shear stress, will affect the blood's resistance to flow. As you can see, its viscosity will go up as these forces change, where plasma and water do not change. Water is Newtonian, so a glass of water is 1 centipoise, as we call it, based on the French scientist, which is really flow and distance. And you pour it over the sink, it's still 1 centipoise. Blood is different. A glass of blood is like ketchup. You pour it over the sink, eventually, like the old Heinz commercials, it can become like water. So blood has a different correlation to flow dynamics. So why is that important? Well, think of where atherosclerosis occurs. We're trained that the endothelium are toe-to-toe, but actually, the endothelial wall is like shingles on a roof of a house. And like water going down the roof, water stagnates or goes backwards. What's going to happen to the roof? And the same thing happens with blood flow in the arteries. And where all blood flow occurs abnormally, and I'll show you this, is where atherosclerosis occurs, such as the coronaries, carotid, the abdominal aorta. So normal veins, which does not ever develop atherosclerosis, blood flow during cardiac cycle is always positive. It's slow, it's always positive, very minimal pulsations, as you know. A normal artery, radial artery, mammary artery, blood flow is always positive. So the deposition of atherosclerosis is very minimal to non-existent. Arteries that are prone to atherosclerosis, coronaries, carotid, abdominal, or femorals, during the cardiac cycle, one moment blood is stagnant, reverse, the viscosity goes up, the BMX endothelial wall goes up. High shear stress arteries are different, as you can see. But this is more complex than just flow dynamics. Blood viscosity is also associated with the hematocrit. The higher hematocrit you have, the more viscous your blood. The deformability of red blood cell, if you have that poorly deformed red blood cell compared to a deformed red blood cell, that can increase viscosity. Comparing a young red blood cell to a half-filled water balloon and an old red blood cell to a raisin, thinking of pouring a raisin through a straw compared to a half-filled water balloon is much more difficult. And RBC aggregation, which is the temporary aggregation of blood cells binding to each other, can also increase the viscosity. And plasma viscosity itself has an effect on, even though it's Newtonian, has an effect on blood viscosity. And these proteins in the blood, like lipoproteins, can affect all three of these. Well, what does apheresis do this? Apheresis, if you lower your LDL, your viscosity, in the sense of deformability, improves. You change your red blood cell from a raisin to a half-filled water balloon. What about plasma viscosity? Well, that's reduced dramatically also. This is by Chef Warner in Germany that published years ago. RBC aggregation reduced by 53%. So what's the final effect on blood viscosity? What we showed is dramatic, up to a 21% reduction of blood viscosity. So we're changing, I tell my patients, from ketchup to tomato juice. Okay, I think I've gone quite rapidly in this, but I wanted to do so we can get to the next important speakers. So in summation, lipid apheresis is the only FDA-approved therapy for reducing LPA levels in cardiovascular disease events. The additional vascular changes, as I mentioned, may assist in this reduction of events. But obviously, apheresis is not approved for everybody. And primarily, it's not approved for primary prevention. No way would it be approved for that. So what do we do right now for patients in primary prevention for high LPA? Well, I look at LPA as a risk factor that we can't treat at this moment, similar to age. What do we do with age? Well, what we do is we realize that someone at age 65 compared to 25 has a much higher risk of events related to cardiovascular disease and other such diseases, and we address them as we need to. I don't ignore the age. I always want to know someone's age. And it's the same way we should know someone's LPA. If we know what their LPA is, then we know we need to go more aggressively with other risk factors, such as weight, such as smoking, such as hypertension, such as diabetes, such as dyslipidemia, because we know they have an underlying risk that's going to precede other patients potentially of developing cardiovascular disease, such as age. So it's something that we should not ignore, but we should recognize. Next, PCSK9 inhibitors. Although not FDA approved for treating LPA, they have demonstrated significant reduction in CV events when LPA are elevated, as I showed you, despite inconsistent reductions of LPA levels. Unfortunately, it's not approved, but you can see it can be a benefit to some patients. And finally, until newer therapies become available, as I just mentioned, more aggressive therapy and treatable CV risk factors should be implemented. I'll stop here and pass it back to Alan. Thank you.
Thanks, Pat. That was fantastic. And really considering the coverage of so many things, you've made that so succinct and understandable. I appreciate that. All right, we'll go on to our next speaker, close friend, Dr. Jamie Underberg. Jamie is a clinical assistant professor of medicine at NYU and director of the Bellevue Hospital Lipid Clinic, and also a past president of the National Lipid Association. And he's going to talk about emerging therapies for LPA reduction and what's coming down the pike beyond LDL apheresis. Jamie?
Thank you, Alan, and thanks, Pat, for such a wonderful overview of apheresis. Every time I listen, I learn, and that's the best part of these programs, I think. So, again, I am tasked with discussing newer therapies or emerging therapies for LPA reduction, and makes my job a lot easier after Pat's wonderful overview of the topic area. I spend my time both at NYU and Bellevue hospitals, where I did my training actually, and we have a lipid clinic at Bellevue. We're lucky enough to see people from all over the world who come to us with fascinating lipid disorders. And so our outline here is to review the impact of inclisiran on LPA, and then some newer therapeutics that are not available yet, but maybe in the future. Pelacarsen, which is an antisense oligonucleotide, and then some small inhibitors of RNA or siRNA therapeutics, olpasiran and SLN360. But first, before we jump into the newer therapeutics, I think an important question to ask is, when we think about the development of LPA lowering interventions, is this concept safe? Pat showed you some really great information on apheresis, but what other information exists out there to make us feel comfortable with moving ahead with the process? Because when you ask folks, why do we have LPA, the conversation goes off in a lot of different directions. And so when we look at both observational and genetic data, which are naturally occurring subsets of information to sort through this question, we find that there are both concordant and discordant findings that support the safety of LPA lowering as a concept. There's a lower risk of cardiovascular disease, myocardial infarction, aortic valve stenosis, and ischemic stroke in observational data sets in patients who have lower lipoprotein A levels. And then there's no change in the risk of cancer or infectious disease or other diseases. And then finally, there are some discordant findings, increased risk observationally only with regard to mental disorders and diabetes. When we look at the safety of low LPA in large population cohorts, this seems to again be embraced by the data, with here no change in the risk of cancer and infectious disease, where the lowest and highest quartiles of LPA are compared. So I think when you look at the overall compendium of data, I think the concept of LP(a) lowering is a reasonable and safe one to pursue. So the next question is how aggressive should we be? What do we need to accomplish? And so here, what I show you is some fascinating data based on some of the genomic predictive values that have been developed comparing LDL cholesterol lowering and LP(a) lowering. And we know that to lower events based on LDL cholesterol lowering, you need to move the bar somewhere between 30 to 40%. And this is just an example of how much you would need to lower LDL in millimoles per liter if you were going from, say, the 90th percentile to the 50th percentile. If you look at similar reductions in LPA, it seems like ideally we need to move the bar about 80%, which means that at lower LP(a) levels, you need to actually be more aggressive about the methods you use to lower lipoprotein A. So when looking for ideal interventions to move the bar from a risk perspective, there need to be rather robust changes in LPA if we were going to actually be pursuing this from a clinical trial perspective. So Pat showed you this data, but just to review, again, statins increase, but probably no adverse effect, both from clinical trial data from Jupiter and from meta-analyses, one recently published in The Lancet. Ezetimibe, no change. We talked about niacin. Bempedoic acid, no change either. PCSK9 inhibitors, about 25 to 30% reduction. We'll speak about inclisiran, about a 19% reduction. And then obviously there are some other drugs on the horizon. CETP inhibitors, one that interestingly enough does change lipoprotein A levels. Well, why do we want to do this? Well, again, we think about the risk associated with lipoprotein A, both from a cardiovascular perspective, myocardial infarction, from a perspective of stroke prevention perhaps, and also possibly from the prevention of progression to aortic stenosis. Whether that is pursued earlier on or later is really a fascinating topic for debate. And so when focusing on new pathways to target lipoprotein A, again, reducing MI or potentially even reducing aortic valve disease are two of the targets that investigators are focusing on. I think, again, potent lowering of LPA is key here, somewhere between 50 to 100 milligrams per deciliter, or as I mentioned, upwards of 80%. Are really the targets I think we need to look for successful programs with regard to lowering of lipoprotein A. So I mentioned three that I'm going to be discussing today: the antisense oligonucleotide pelacarsen, and then there are two small inhibitors of LPA, the SLN360 and olpasiran. So when we think about how these mechanisms work, I think it's important to understand the difference between antisense oligonucleotides and small inhibitors of RNA. Ultimately, they both stop the production of the protein ApoA that binds to LDL that creates the LPA particle. Antisense oligonucleotides, this works by binding antisense snippet of the nucleotide to the mRNA that codes for LPA, essentially creating a duplex strand that is recognized as abnormal by an enzyme called RNase, and this breaks down the specific piece of messenger RNA that codes for ApoA and essentially stops the production of the protein. Small inhibitors of RNA work through a pre-existing mechanism that is called RISC, or RNA-induced silencing complex, activating that to essentially go off and target the specific piece of RNA that codes for the ApoA protein in this case. And so these are the drugs in development that we've mentioned, pelacarsen. Again, it's being studied, all of these, in phase 3 and phase 1 and phase 2 trials to investigate its ability to not only lower LP(a), but ultimately reduce cardiovascular events. So inclisiran is a molecule that's currently available. And inclisiran is an inhibitor of PCSK9. It's not a monoclonal antibody, but it's also a small inhibitor of RNA, and it acts through the same mechanism that I showed you earlier, essentially targeting this pre-existing unit in the cell called RISC, and by activating it, it essentially targets the messenger RNA, in this case for PCSK9, reducing the synthesis of PCSK9 as opposed to monoclonal antibodies targeting PCSK9 that block its action once it's already been made. Well, like pre-existing PCSK9 inhibitors, monoclonal antibodies, inclisiran, also an inhibitor of PCSK9, lowers lipoprotein A. The mechanism by which PCSK9 inhibitors lower lipoprotein A is still much up for debate, and I'm not going to get into that today. I am going to show you just some brief data on inclisiran and just remind you that it's a very potent reducer of LDL cholesterol, somewhere between 45 and 50%, and what makes it unique from the pre-existing monoclonal antibodies is its frequency of administration. Rather than giving it every 2 to 4 weeks, after an initial and a 3-month starting injection, it can be given every 6 months. And so dramatic potential for improved adherence with inclisiran. If we look at inclisiran and lipoprotein A reduction, you can see here in the Orion 11 trial, patients were looked at who had elevated lipoprotein A. And this was the baseline demographic and clinical characteristics of this group. And you can see that the reductions in lipoprotein A were modest. Lipoprotein A changes by percent reduction here, about 28.5%. And if you look at the absolute change here, you see in nanomoles per liter, it was 16.9 nanomoles per liter. So this is similar to some of the numbers that we've seen with the pre-existing monoclonal antibody PCSK9 inhibitors. And if you look at the percent change here, this is from the Orion 1 trial, you can see that it's dose related. And when you get up to the higher doses, I boxed out this area in red, you can see that we get up to percent changes somewhere between 18 to 25%, depending on whether it is a single or 2-dose regimen. And obviously, because inclisiran has to be administered first at 3 months and then at 6 months, it wouldn't surprise me that the multi-dose regimen is what's required to get the greater lipoprotein A lowering. But again, PCSK9 inhibitors, as Pat has pointed out, are not approved for lipoprotein A lowering. So let's move on to drugs that are actually being developed specifically to lower lipoprotein A. And pelacarsen is the first I'm going to discuss. This is a second-generation antisense oligonucleotide. It is a GalNAc moiety attached to it, and what this does is it specifically targets the pelacarsen to a receptor on the surface of the liver. Some more specificity with binding. You can give lower doses with more efficacy, and that allows a greater reduction in lipoprotein A, along with potentially reduced side effect profile. And so these GalNAc moieties, second and third generations, are very useful. And they're used in a variety of different antisense oligonucleotides, not just pelacarsen. As far as the mechanism of action here, I've already gone over it briefly, but again, the antisense oligonucleotide finds its way ultimately to the specific piece of mRNA that codes for the protein you're trying to target, in this case, the mRNA for ApoA that's involved in the production of LPA. It creates an abnormal duplex strand that is recognized by a specific enzyme called RNase that then breaks down that specific duplex strand, essentially inactivating the mRNA and inactivating production of the targeted protein, ApoA in this case. So if we look at LPA cutoffs signifying increased risk in the effect of therapeutic agents that might achieve these targets on the right, you can see here that based on a variety of different currently available therapeutics, such as niacin, monoclonal antibodies, formerly mifemersen, and maybe in the future CTEP inhibitors, the effect of apheresis compared to the potential effect of pelacarsen, which I'll show you in a minute, lowers LPA somewhere between 70 to 90%. This falls into that sweet spot that I mentioned, where potentially we may need to achieve to find effective reductions of ASCVD events. Pelacarsen has been studied in phase 1, phase 2, and now ongoing phase 3 trials, looking at reduction of LPA, and you can see that it has achieved, at its higher doses, given anywhere between every 2 to 4 weeks, reductions in lipoprotein A north of 80%. And so this certainly is intriguing. There is an ongoing clinical outcome trial looking at the use of pelacarsen at 80 milligrams once a month. And these patients have to have a lipoprotein A greater than 70 milligrams per deciliter to enroll in the trial. This is some early phase data looking at the effect of LPA lowering with pelacarsen. This was published in the New England Journal of Medicine. At the higher doses, given between every 4 and every 2 weeks, reductions between 72 and 80%. So again, reaching reductions that we'd like to see. Absolute change with pelacarsen at 6 months from this one clinical trial. You can see higher levels of reduction or greater levels of reduction at the higher doses given every 2 to 4 weeks, anywhere up to 60 milligrams. What about adverse events? I think it's always important to talk about this when we look especially at new drugs in development, but I wanted to pull out the serious adverse events because I think that's really what we want to know about. And you can see compared to placebo, there is an increased risk. Most of these fall into very tolerable categories, but again, you do have to pay attention to this, and that's why we do the clinical trials, to make sure there are no issues when we look at safety versus event benefits. So the ongoing clinical trial for pelacarsen, it's called LPA Horizon. It's a CV outcome trial. It's a phase 3 study looking at the risk of reducing major cardiovascular events in patients with pre-existing ASCVD and elevated LPA levels. They're going to receive monthly sub-Q injections of pelacarsen at 80 milligrams. And you saw, I showed you some data for the 60 milligrams, approximately over a period of 4 years, over 8,000 participants. To get into the trial, it's important to recognize this because there are differences between some of these trials. Previous MI or ischemic stroke, at least 3 months but no more than 10 years before screening, or current symptomatic peripheral artery disease and a lipoprotein A level greater than 70 milligrams per deciliter at screening. And again, we should have data on this hopefully by late spring of 2025. So next I'm going to move on to the second agent I told you we would discuss. This is a small RNA, small inhibitor of RNA called olpasiran. And so the technology here is very similar to the technology I showed you for inclisiran, a PCSK9 inhibitor that works through inhibition of RNA through this siRNA mechanism, activating the RISC complex, or RNA-induced silencing complex. And so this is some early phase 1 or preliminary data that was published in Circulation in 2020, looking at safety, tolerability, and efficacy of olpasiran. And you can see in this particular data set that the reductions in LPA at the higher doses, when you look at the blue lines or the green lines down towards the bottom, LPA lowering, again, somewhere between 80 and 90%. So very encouraging with regards to the degree of LDL lowering. Again, the mechanism for siRNA reduction is through the RISC mechanism, so very similar to what I showed you before. This is subsequent data that has now been published in the New England Journal of Medicine, looking at the use of LPA in patients with cardiovascular disease. If we look at percent change in concentrations of both LPA, LDL, and ApoB from baseline to week 36 in this particular trial, you can see very aggressive LPA lowering, upwards of 95 to 97%. I mean, this is really pretty impressive. And again, similar reductions across the board depending on the dose of olpasiran that is used in these particular clinical trials. LDL goes down also, and in LPA lowering drugs in development, this is something that we see. And so it's important to remember that when we look at clinical outcomes in these trials, we are going to have to adjust to the effects of LDL lowering along with the effects of LPA lowering in these trials. percent change in LPA concentration, and the placebo-adjusted mean from baseline. This is, again, with olpasiran, weeks 36 and 48. And you can see here, again, reductions that are rather significant at the higher doses. If you look at percent change, you can see reductions upwards of 90% or even higher. What about the distribution in LPA response? I mean, you always want to know, is everyone getting the same benefit from these drugs? And if you look at the higher doses, the answer is probably yes. At the lower doses, there seems to be a heterogeneity of response. There is variability even in patients who aren't treated with anything. But again, when you get up to the higher doses, pretty consistent reductions in LPA in all of the patients who received the active treatment. Again, what about adverse events? I think this is key and important for any discussion in new drugs in development, so I pulled this out for you also. When you look at SAEs for serious adverse events and adverse events leading to discontinuation, which in my mind I think is really one of the key things you want to know about, very similar to placebo with this therapeutic. Other trials that are going on with this medication, there is an outcomes trial, just like there is for olpasiran. This is called Ocean A outcomes trial. A little different, so it's important. That's why I wanted to go over the first one in a little more detail. Here again, looking at the effect of olpasiran subcutaneous once every 12 weeks, so it's being given less often, all right, every 3 months essentially, to placebo, on the risk of coronary heart disease, death, MI, or urgent coronary revascularization in patients with ASCVD and elevated LPA. Little smaller trial, 6,000 versus more than 8,000, again, 4 years, so similar time frame. Primary outcome time to CHD death, MI, urgent coronary revascularization. And inclusion trial criteria a little different here. History of ASCVD as evidenced a history of either MI and or coronary revascularization. And that can be with percutaneous intervention and at least one other risk factor with stenting. So what's different here, what's not in that inclusion criteria, is stroke or peripheral vascular disease. Finally, there is a third drug that I wanted to discuss briefly, another siRNA inhibitor called SLN360, works in a similar fashion to the previous drug that I just discussed, olpasiran. And again, when you think about the benefits of siRNA inhibition, it's obviously efficacy, but it's also more or less frequent administration. I mean, these are really the benefits of using these therapeutics. And so again, here in this earlier preliminary phase 1 data that was published in JAMA, you can see that when you get up to the higher doses, and this was interesting because this, again, a small trial done early on in the development phase of this drug, it's just a single injection of the medication. It was not multiple injections. And I think what's interesting about this is when you see there was groups that got the placebo and then the 30 milligram dose, which is in the gray here on the right, there was a moderate reduction, but when you get up to the 100, 300 milligram doses, rather aggressive LPA lowering, again, similar to what we saw with other siRNA inhibitors for LPA. What's interesting is not much of a difference between the 300 and 600 milligram dose, so really what happens when you get up to the higher doses with these drugs is what you see probably is a longer duration of action, but not necessarily greater efficacy. And that's actually something we've seen with PCSK9 monoclonal antibody inhibitors too, that once you get to a certain dose, the benefit of escalating dose seems to be duration versus improving efficacy. Of course, when you get to 95%, I'm not sure how much greater efficacy you would expect to see. So in summary, patients with LPA have obviously a genetic predisposition to increased risk for ASCVD events. Obviously, we want to measure this, and Pat gave us some really good reasons why one would want to measure this. I'm always fascinated by people who say, well, I'm not going to measure it because there's nothing to do about it. Well, first of all, there are things to do about it. And second of all, that would be tantamount to saying, well, I don't want to know about your family history. Obviously, it alters the way you think about the patient. And their risk of vascular disease, risk of cardiovascular disease, and aortic valve disease, I think are all important things for us to consider to this. And now, obviously, therapeutic interventions on the horizon on top of what we currently have available. Pat mentioned, obviously, LPA apheresis and currently available monoclonal PCSK9 inhibitors and siRNA PCSK9 inhibitors. And so at that, I will stop and say thank you, and I will pass the baton back to Alan.
Thank you, Jamie. A fantastic presentation and a great summary on the therapeutic agents on the horizon. And I think everybody's heard a common theme that measuring LPA makes sense. And it makes sense because you're going to worry more about the patient and be more aggressive with all of their risk factors, and keep them on the list for, as newer therapeutic agents become available, and also if you're lucky enough to have an apheresis center and the appropriate patients to be able to consider referring that patient. So I'd just like to thank everybody for joining us for session 2, and hopefully you enjoyed both sessions. Please take the post-test and complete the evaluation to get your CME credit. And thank you all for taking time to join us for this presentation today. And thanks to the wonderful faculty for this program. I appreciate all of your thoughts and comments.
Thank you.
Thank you, Alan, Jessica, Jamie. It's an honor.
It's good to be with you.